Wait till the 10:30. Wait till the 10:30 thing. Well, it just turned 10:30, and welcome to Brainstorming the Human Connection, brought to you by the South Dakota Humanities Council. My name is Lawrence Diggs, as you can see on the screen, and I'll be your host. And probably in sometime in your life, you have contemplated, what it's like to have palliative care, or maybe you haven't, but you should, because if we live long enough and our lives are fruitful enough, many of us will face palliative care. And some of us may even face hospice. There are more and more people becoming aware of it. We used to have hospice. I mean, we have had hospice for, I suppose, as long as there's been people, but we haven't talked about it much. We, especially in our culture, we tend to avoid the topic of our demise or even just diminished capacity. We don't usually like to talk about the time when we will be dependent on others. And we like to think about, the person who is able to take care of themselves and do everything for themselves, though that's actually never really the case. But we can illusion ourselves better when we're younger and we have full health. As things go on, we find that we have more and more problems taking care of ourselves as we get older, and others, we will need the help of others. That's particularly true when you live in a marginalized society. And today we're going to be taking a look at some of the extra stresses that happen on our reservations and with Native Americans in general. But this is not exclusive to Native Americans. It just maybe has some extra couple of pounds on the hammer, because there's some obstacles that we don't even recognize because they're taken care of for us, that they may not have that help. So today, our guest is Mary Isaacson, Dr. Mary Isaacson, and she's the Associate Professor of Graduate Nursing in the College of Nursing at SDSU. And she's involved in a very special project that has to do with the needs of elderly and aging Native Americans in South Dakota. So, Mary, welcome.
Good morning, and thank you for inviting me to be here. So it's a pleasure, and I look forward to the conversation.
Thank you, and it's a pleasure to have you. And I'm hoping that we will all learn something, and maybe even find some little or large things that we can do, even if it's just being more aware of the different difficulties that some people are facing that may be below our radar. So let's talk a little bit first about Mary. Who is Mary? How did you come to be the graduate, the Associate Professor of Graduate Nursing and all of that? What led you to this position? And then we'll get to some of your work later, but just who is Mary?
Oh, great question. So I am not a native of South Dakota. I'm actually from Iowa, although my husband says you've lived in South Dakota more than you lived in Iowa. It's now time to call yourself a South Dakotan, which I do. And I've been a practicing nurse for 41 years, which is kind of shocking when I think about that. And the majority of that career has been in rural nursing, because I currently am living in the Rapid City area, because South Dakota State University has 4 nursing campuses: Sioux Falls, Brookings' main campus, Aberdeen, and then Rapid City. So I'm in the Rapid City campus. However, for the majority of my career, as I said, I was on the southeastern side of the state where Vermilion was home. and for a number of years worked in the rural Vermilion area and was the hospice coordinator, where you had a 50-mile radius where you cared for people who were at end of life in their homes. And this is before the time, and I always kind of laugh when I think when I'm working with students, before cell phones, before the 911 marker systems. So when you went to go visit somebody or somebody needed you at 2 a.m., turn left at the big oak tree with the Kent feed sign, and then it's another mile down the road, go up a hill. So that was how you got around. And for some reason it worked, and, still does to an extent, but with the evolution of technology and things, that component has become much better. Fast forward, then I went into education, but my master's is in community health nursing, which is still my passion. And then obtained my PhD in 2009 because I saw a huge need for nursing research and the role of a nursing scientist, because nurses bring so much value to healthcare, because we are so person-centered and so holistically centered that we're able to have these conversations with people to really learn, what is this experience like for you, and how can I best help you through whatever that experience is. And my work then really started with individuals on the Pine Ridge Reservation in 2008, where I have been working and conducting research with the community since. And now it's extended into Rosebud and Cheyenne River as well. So that's me in a nutshell. So I've been with SDSU since 2013. So
that's a very large nutshell. There's a lot of stuff you packed into that. And I'm always surprised when people start their nursing careers at 9 years old. That's always, that's always, yeah. Okay, so now I would like to look now at the work that you're currently doing and tell us a little bit about that. What's the 50,000-foot view of the project that you are involved in now?
Well, I'm involved really in several projects, but the overarching one is really about improving palliative and end-of-life care services for individuals living in our tribal communities here in South Dakota. And it really stems from the broader picture of understanding the vast issues of health disparities that exist for our individuals who live in our reservation communities. I think there is a huge misunderstanding across the state and across the country regarding Indian Health Service and healthcare in general for our tribal communities. Many people think that Indian Health Service is free healthcare and our natives should have no problem. Their healthcare needs should all be taken care of. However, many individuals forget that Indian Health Service is funded from the federal government through appropriations, and essentially it's whatever money is left over they receive. So they are severely underfunded. And they typically say, do not get ill after June because there is no money. So preventative healthcare services like those of us who have primary care physicians, et cetera, are severely lacking in our Native communities. So understanding the healthcare needs is tremendous. So now we have these individuals with a lack of preventive healthcare services. They are often, when they're diagnosed with cancer, it is at later stages and more advanced and at more advanced stages. And the ability to manage symptoms or to receive their oncology services, if we think about where our reservation communities are located, you're in Pine Ridge. Well, you have an hour and a half to Rapid City. But what happens if the care that you receive is unavailable in Rapid City? Then is it Omaha? Is it Denver? If you are in Rosebud or Mission, where do you go? Do you go 3 hours to Rapid City? Do you go 3-4 hours to Sioux Falls? So travel is huge. And I know that isn't specific just for our tribal communities. It's also for our individuals who live rural, because we are a rural and frontier state. So getting back to your question, the biggest picture now is since 2014, I began working with our American Indian population in Pine Ridge, specifically with tribal educators and tribal elders, about what is palliative care, because palliative care is poorly understood across the nation. Palliative care is a specialized health care or medical care that can be started at any time of a serious illness. And a serious illness is cancer, kidney disease, diabetes, heart disease, lung disease, the whole gamut. Even a major motor vehicle accident can be a serious illness for a time. Palliative care is where we look at the individual holistically, recognizing that physical needs are of utmost importance, but also there are spiritual, emotional, social, and physical, emotional, spiritual and emotional needs that need to be addressed. Because sometimes those physical needs are all taken care of, but yet that person is still suffering from extreme anxiety. Well, what is it? So how do we identify that? And it works within an interdisciplinary team approach of nurses, physicians, social workers, chaplains, can be pharmacists as well, to recognize that there are all these facets to providing well-rounded care. So we have these individuals. What is palliative care? And then hospice, and this is where it really becomes kind of sticky. Palliative care, as you can see, any time of a serious illness, seeking aggressive or curative therapy. In the United States, because of the way we define hospice, and it's seriously because of Medicare and insurance, that hospice and palliative care are separated. Hospice in the United States has to be, in order to be paid for, is under Medicare, a person has to be certified by their attending physician of having a life expectancy of 6 months or less to live. And that's a payment mechanism. Now, if you went to receive hospice care in the UK or Australia or in Europe, palliative care and hospice are seamless and synonymous. So they would transition, maybe you're receiving palliative care for this serious illness, and then as your life, it looks like, the care is no longer working, it's still palliative care throughout. It's just a name, is really what it is. And so essentially, hospice uses palliative care principles. In the United States, it's during those last 6 months of life. And that's what differentiates the two. So again, brought that information back because it's a very Western medical model. Does this work within our tribal communities? And overwhelmingly, yes, this is what we need. And what they said after we had worked together for 6 months to see, okay, if we were to start this, what would it look like? What cultural tailoring would need to happen in order for a program to start? And what these elders said is, we need to understand advance directives, living wills, and last wills, most importantly. And we received funding from the South Dakota Department of Health and the Comprehensive Cancer Control Prevention Program to develop an advanced directive program where the Lakota elders, we developed an advanced directive brochure and put Lakota terminology, Lakota artwork on it. And then I provided them with education. How do you talk about palliative care? How do you talk about hospice care? And then how do you differentiate between what is an advanced directive, what's a living will, and what's a last will? I think one of the clearest conversations that I had with one of our elders, we kept talking about this durable power of attorney, this medical durable power of attorney. And she said, well, what is that? And I said, well, it's your decision maker. Well, why don't we just say that? And that's, again, a big problem with healthcare, because we use this terminology instead of just making it so that anybody can understand it. So very clearly on this brochure, it's your medical decision maker who can help you make those decisions, or make them when you are unable to make them when you're unable to make those decisions for yourself. Fast forward, another group, Massachusetts General Hospital from Boston, has a rural health fellow program on the Rosebud Reservation at the IHS facility. I had been in contact with Rosebud, and they came in contact with me. They said, we really want to try to develop palliative care and better understand it, and how we can get something going in these 3 tribal communities. And we are currently under a National Cancer Institute grant where we're working with Cheyenne River, Rosebud, and Pine Ridge. We're in the 4th year of this grant. The pre-process was where we did talking circles with American Indian cancer survivors, family caregivers. We conducted interviews with tribal leaders and tribal healers about what does it take to live well with cancer in our tribal communities. And from that information, really have now developed a trial program where we are working with Avera Walking Forward and Avera Health. And we did a training program with lay workers who are from Avera Walking Forward, which is a American Indian Cancer Navigation program. And these individuals are located in the reservation communities, and we have provided them with, they don't provide palliative care, but what they are is this layer of support to bring resources. Okay, so you need a hospital bed. We need a wheelchair. Oh, your medications aren't refilled. Are you having pain? What questions do you have? And really trying to be that kind of connection point to connect them to those resources. And right now we're in that starting phase of that. So I don't have any results yet to share, but we're hoping that that can be a model. It isn't true palliative care, but if a person is found that their symptoms are not being managed well, is there a potential that we can connect them to a palliative care specialist at Avera? Yes, possibly through telehealth services. So that's, always on the radar. Another companion grant that I'm on with another colleague of mine, Dr. Jennifer Anderson from Brookings, who's a health communication specialist, is we're developing palliative care messaging specific to these tribal communities. Because as we know, palliative care is poorly understood. So how do we talk about palliative care? So if we have this program, how do people ask for it? How do they know what it is to understand its usefulness? So, and that again is we're in the first 6 months of that grant. So that's in a nutshell, in a very long nutshell. Sorry.
No, that actually prompts a lot of questions and things that we should kind of get under the hood of. One of the things kind of at the top of what you were saying about that is you mentioned that there's this durable power of attorney, but then people say, well, it's just your decision maker. And as you said, like, oh, why don't you just, someone says, well, why don't we just say that instead of durable power of attorney? That brings to mind, the idea that, when you say durable power of attorney, that term comes from a long history of like trying to work out how all of these things work. And somehow they probably started with your decision maker, but realized that there's a lot under the hood. So there are different kinds of power of attorney. Mm-hmm. And all of them are decision makers. So how do you make it understood that there are these different kinds of decision makers when you have one word that covers all those terms? And then there's all those things that it could mean. Doesn't that sort of set up people for misunderstandings? And if so, how do you deal with that?
I think it's just constant communication and revisiting it, because you're exactly right. When I would go into an individual's home, when I was providing hospice home services, and you talk about, and do you have a medical power of attorney? That, yeah, my daughter has complete control over my checking account. No, that's a different power of attorney. And so really trying to explain that. And I think, again, that as exactly as you said, Lawrence, it's that use of power of attorney. So which one? So you have your financial person, and then you have your medical or your healthcare person, and really having people to understand that. And sometimes even just writing it out in simplistic terms is very helpful. Because especially and when people are at end of life, and when we're unable to make our own decisions, or too tired, fatigued, you need that person to be able to pick it up at that time and to say, Mom wouldn't want this, or this is what Mom specifically said that she wanted. Now, if you have an advance directive, it's in writing, and they are supposed to be legally binding, but they can be overridden. So that person that you select, or that we select, really needs to know your wishes, and you need to be very, very specific with them. So it's not only having this piece of paper, but then talking to your family member or that person that's been in charge. Because we've had that too, where individuals, you'll go out there, well, my daughter's my durable medical power of attorney, and the daughter will go, what? And they didn't even have the conversation. Or I've also heard families say, well, I didn't want my brother to feel bad, so I made him be the medical power of attorney. And that person cannot make those decisions because they're too emotionally, not that we aren't all emotionally tied, but it would be hard for them to honor those wishes because of how they feel. Does that make sense? So it's a very calculated, unfortunately, decision that you need to make.
It does make a lot of sense, and it kind of raises the question too of like, how do you raise the general knowledge of the general population, not only on reservations, but just out here in the rest of the world as well, raising the awareness of these terms to the point that not only the person who's affected, the medical person, the patient, but also the people who are agreeing to be that durable power of attorney, because often we don't have people who understand that we can assign that to. We may have the emotional and connection to that person, but that person may not be the person who knows how to, let's say, argue on your behalf, because someone has to stand up for you. Even though they have that power of attorney, they may not be the person who has a strong enough personality to say, no, you will not do that, or you will have these consequences. You will do this, because this is what the person wanted. Those are often different people, So I'm wondering, how do we raise the general awareness of pick a population, that they have choices of who to pick, and know that these are the considerations that you have. I'm wondering, how are you dealing with that?
Well, personally, I'm not dealing with that, but there are other programs across the state. I know that Monument Health here in Rapid City had a program going. I believe USD also did that, and it was like the Conversations Project, because way back when, La Crosse, Wisconsin was known of having the highest number of individuals who actually have an advance directive or a living will, and where people just sit down and they have this conversation. So it requires, kind of that boots on the ground and community conversations, where you go out into the community and you provide education. And sometimes it's just, let's talk about it. Doesn't mean anybody has to make a decision right now, but it's at least to plant the seed and have people really think about, well, what would I do in that instance? Because This, in the United States, they often say we're a death-defying society. We will, because we can, we just need to do everything. And sometimes that's not the best course of action. It actually causes more harm than it actually does good. So we need to be less fearful of those conversations and know that saying that at any time you can change your mind, but what would you want to do? And really have that. And then say that you have a community meeting, then you need to revisit it. It just can't be, again, that one and done philosophy. It's coming back and revisiting in that. And then also knowing that I was in the Navy Reserve Nurse Corps for 22 years. So I had to have an advance directive at the age of 30. Now, would my advance directive look completely different at 30 than what it does now at 60? Absolutely. So even when you have it documented, it's making sure, is it up to date? Have things changed? Has the person that you wanted to be your decision maker changed? So again, community conversations to plant the seed, to talk about it, going back and revisiting it, and then making sure that it's followed through. But that takes work, and again, takes financing sometimes to do that too.
Yes. Well, I would add that in addition to being a death-defying culture, we are a death-denying culture too. We will not accept often that, death is part of life. Mm-hmm. That said, we have an esteemed panel who have assembled here today with us on Zoom, and I want to throw it out to them, the opportunity to ask questions, make comments. Remember, this is an interactive program. We invite everyone to participate. Just need to raise your hand or turn on your mic, and let's get a conversation going. Let's start with Betty. She looks like she's greased and ready for action.
I've had my coffee this morning. Thank you so much for this program. I have just a casual personal life and a little bit of professional experience being around this very issue of end of life and durable power of attorney and choices and what does it all mean. I'm interested to know if anyone is doing these community conversation groups within South Dakota, thinking that it might be something I could, put together, organize for people to come together in Aberdeen. But who do you have facilitate that if there's not a group? There are attorneys and there are doctors and nurses and all, but how did that work out, or how did they organize that in your understanding of what was done from that Massachusetts project?
That's a great question, Betty. And I will be honest with you, I will have to get back to you, and I can get back to you or get back through the South Dakota Humanities Council so they can put that out. I'm certain there are probably groups out there that are doing it. I haven't heard of any groups currently doing that, but that could be because I'm not really in that area right now doing that kind of work. But I could certainly get back, because typically, you're right, the hospital, not necessarily the clinic, but maybe the hospital has a program or somebody that would be willing, that they have maybe community education that individuals will be willing to come out. And yeah, we could provide a program on that, and we can actually even bring forms for people to look at. That would often be, because you said you're in Aberdeen, right? Or in the Aberdeen area. You might want to check with their, community outreach department or something. Do they have something like that they'd be willing to provide?
Betty, if you put your name in the chat and your email, I work through Sanford and I'm one of the facilitators for advanced directives. And I'm not in Aberdeen, I'm in Sioux Falls, but I know we do trainings for our different facilities throughout the region. So if you give me your information, I can see who is the people in Aberdeen to contact for you.
That'd be great. Thank you so much.
You're welcome.
Wonderful. Thank you, Carla.
Yeah, I think that's a very good connection, Carla. And maybe you could put your contact information in the chat as well, so others who are looking for information or who might want to do something along these lines would be able to get in contact with you and get further information. Anyone else have a question or an answer or comment? Anybody else? Okay, going. Go ahead, Marge.
Betty just had a great idea. I'm thinking about the Brookings area, if something could be put together from there, from the hospital or so. I think that's a great idea.
Yes, I'm glad you mentioned that, Marge. That is really one of the purposes of this program, is to make those kinds of solutions rise to the top, and then people can say, oh yeah, I could use that. How do I make that happen? And often we're unaware of a problem, let alone a solution. And then when we think of what might be a solution, we often don't have means. We don't know, well, who do I contact? How do I even think about this problem so as to think about how I might solve it? So please do get in touch with Carla, and let's see if we can't make these kinds of services more, let's say, normalized, not only available, but just that people know it. Maybe we could rise to the level of Wisconsin and have almost everybody know, oh, I know what that power of attorney thing is. Just feel it's normal. Okay, so let's continue. If anybody else has any
I do have a question.
Go ahead, Joey.
Every year, as part of my Medicare checkup, I am asked by the doctor's office, the hospital system, to fill out an advance directive and a medical power of attorney. So that's how it's handled here. I don't know, extensively if other doctors' offices and hospital systems have made that part of the Medicare checkup, but that's for me. So my question is, the durable power of attorney, at what point do you decide that that is a necessity? Because it's handling the financial matters, but as long as you can handle your own, is there a reason to establish the durable power of attorney? I've had it for group trips and that sort of thing, in case of emergencies, but it was very specific, time-wise, ability to do things wise, and a very temporary setup. I just don't know that it's possible to make a durable power of attorney many years in advance. As you pointed out, things could change, but apart from that, isn't that sort of, it needs to go into effect when you can no longer handle your financial questions. So at what point is that something that should be done? Is it when you go into hospice, into palliative care? Yeah, I would think at that point, but not in advance.
Jolene, that's a loaded question. And I think it's an excellent one. And it's really, I will use my own example. My husband has power of attorney over our healthcare, or my finances, should I be unable to handle them, and vice versa. So ours is in effect, at any time should that happen. And then he is also my medical power of attorney should I be unable to answer those questions, or to respond to healthcare questions or what I would want. So that conversation has already happened. I would say, it has to be your comfort level, but we never know, if a sudden illness will happen. We never know if we're going to be potentially in a devastating accident of some sort where we're unable to manage them. But again, it is kind of a scary thing of thinking that if I give this person control over my finances, what's going to happen? So again, that has to be a personal decision. And if you have already worked with an attorney on a last will or anything like that, that may be when you want to talk to them about when do you think I should do that. Because for each it's an individual decision and it depends on how much planning. So.
Does that answer your question?
Yes, thank you. That's great.
Well, it raises a question for me, and that is, let's say you make this power of attorney and you even, register it with your attorney. And let's say you move to another state or something like that, and something happens to you and you're, let's say, on life support or any of the number of things that those kind of things handle. How would someone know that you even had a power of attorney? I mean, we don't wear power of attorney bracelets like some of the other illnesses. So how does someone know, that the person who doesn't know you, that you have like a legal apparatus in place to direct what should happen to you, where you should be buried, all those things? How does that work?
Conversation. You need to communicate it to somebody, because you're right, Lawrence. If you haven't talked to anybody about it, say that you have a close personal friend that, oh, by the way, I have written all of this up, or is it your children that know, or your significant other, however that is, because it often is, you don't even know it exists except for through the privacy of your attorney's office. So you need to not only draw up the documents, have them, but then also let people know that they exist. So I have done that with my own children. So
is there no central database where people who have those things in place that you can just say, okay, like check the database? They seem to be able to find like who's your relatives if you die in England. So it just seemed like, you should be able to have something like that. Yeah.
not to my knowledge. I think it'd be great, but not to my knowledge.
I was thinking the same thing, is like there is no such thing, but I have not studied that. But it would just seem like, even if there is, the fact that I don't know about it makes it kind of like useless until that is general knowledge where to go look that up, or something like that.
This is
Well,
Carla. I had a question if we,
Yeah,
I was
go
just,
ahead.
Mike had one, well, two things. One, there isn't a database. That's why we ask people to put a card in their billfold that has who to contact in case of emergency, and then we always ask people when you fill those out to make sure your primary care physician and any hospital that you are, tend to go to. So like in Sioux Falls, Avera and Sanford both have mine. I work at one, but I might end up at Avera. So that way they have it on file, and you can do that by sending it to their health information systems, and they can put it in with your date of birth, and they'll create a spot for it so that it's there. But I know Mike was asking about how they're doing things on the, let's see, you had something about how things are going on the tribes. Are they really picking up on this? Are they starting to do more advanced directives, things like that?
Carla, I wish I could say yes, that they are. When we did our training session with the advanced directives and the living wills, the two elders that went across to the 10 different districts on Pine Ridge, they shared what palliative care is, what hospice is, the importance of what an advanced directive living will are, and then even ways of getting in touch with individuals, because costs can be a very significant factor in drawing those up. But to my knowledge, I don't know if it's gotten better or not. I would venture to say probably not, because again, it's like the grant runs out, and then how do you keep that momentum going once that has happened? I know that as we have these conversations, as we're continually working on the palliative care component, we still are talking about that. And especially when our health advocates, which is what we're calling these individuals, these lay individuals that are trained to do this, that's another conversation that they're having is, okay, what are your decisions, et cetera. And that's the part, that I think then that momentum will start. But I think COVID has also put a huge damper on a lot of this. I know for me, that personal touch, that being out there in those communities always is incredibly helpful to have those conversations. And that we're just starting to get that up and going right now. I think one thing that was really telling for me, because not only when we were doing that first phase of this conversations regarding palliative care, and if we developed it, what would we need to do, and what's critical right now, we also interviewed oncology providers, nurses, social workers, physicians, and also primary care physicians who care for individuals from our tribal communities. And what was very, very interesting and telling across that is there's an understanding of the challenges and the disconnects between, okay, so this individual is seeking services in Pierre, so they are going to the Avera Cancer Center there, and now they need pain medications, and I need to contact the IHS provider either in Cheyenne River or in Mission, in Rosebud, and they don't have it on their formulary. And so we have these terrible disconnects within the system between the federal system and what can be accessed. The other components is understanding the critical importance of spirituality in the care or in the healing process for our tribal members. And we, and when I say we, I'm talking about white, westernized medicine, discount the importance of, Inipi, which is a sweat lodge, the Sundance, and the community in general in that healing process, and how we can embrace that and make that a part of their routine oncology health care. And I'm speaking from an oncology piece because the R01 is from the National Cancer Institute, but it can be across all the different serious illnesses that we mentioned. We had written a manuscript that will be published in the Oncology Nursing Forum. And what was telling to me was when I received a review back, and the reviewer said, I had to look up IHS because I really didn't understand what Indian Health Service was. And to be given permission to add, an additional page to your manuscript is huge, so that I could tell what IHS was. And for individuals, because if you think about nurses that work in oncology, they are those key people that are engaging with these members. And so if they don't understand what our tribal member is going back to, then we're essentially setting up that tribal member for failure when they go back home. We've also recognized that, what we call that the medical version of palliative care, our tribal communities and tribal families, they've been doing it for years because they gather around and they're providing that holistic understanding, but without the extra support of somebody trained in it. So how do we help and bolster that for them? And that's those pieces that we're, still trying to grapple with right now. Does that help answer your question, Mike? Is there more that I could add to that? Okay, thank you.
That actually brings to mind another issue, and it'll lead into the bigger question of general challenges that people have to palliative care. But it occurs to me that just because of our culture, and I'm not so sure it's different in any other cultures, let's say we're unfamiliar with, or uncomfortable, I'll say, with nudity. Yet when our significant loved ones are no longer able to do things like take care, to bathe themselves, to, when they defecate, or urinate on themselves, they feel bad about that, but there's nothing they can do about it. Somebody needs to take care of them. Usually people are not normally, despite their wishes, they don't know how to turn a patient and change them in a bed. They don't know how to change the sheet with the person unable to get out of the bed. They don't have that training. So I'm just wondering, what does palliative care mean if there aren't people who know, especially if they have an injury, how to do that? It's like, what does that look like, despite our greatest desire to help? What does that look like? And what are some of the other challenges that people have sort of taking control of their health care?
Well, I think you raised some really good points there, Lawrence. And I think the key component to that is thinking about, okay, so often when individuals are at the end of life, their preference is to be at home surrounded by their loved ones. But are the mechanisms in place so that it's safe not only for that person who is at end of life, but also for those caring for them? And in our less rural communities where there's a strong home health and hospice program, they provide those resources of a nurse and a social worker and a home health aide to come out and help provide that care and also teach the family. But what do we do when you live in these more remote and frontier areas, such as our tribal communities and also in many of our other communities that are in these frontier areas in the state of South Dakota, where there is no home health or hospice care? And it's essentially the families sharing the burden, doing the best that they can with the limited resources that they can. And it's wrong, but yet we seem to lack the willpower or to really figure out, well, how can we do that? We can do better. So how do we do better? It's a cost thing, because it's a lot, like you said, Lawrence, early in our conversation, it's a distance. And a nurse or a home health aide could be on the road an hour and a half to 2 hours just to get to that place. Well, who's going to pay for that? But yet that's the care that person needs. And we haven't wrapped our heads around that yet. And I don't know, Carla, I see you shaking your head. I don't know, what are we going to do about it?
Well, I wondered about the CHRs. Are they engaged in anything? They're so busy. They've got so many things, but I don't know. I think probably some people know what a CHR is, or CHW in non-tribal, but in the CHRs, I know I've trained for foot care and things like that before for the CHRs. I didn't know if they're involved in any of this kind of care or not.
What is CHR or CHW? Or
right, the community health representative has been a staple within our tribal communities, and it's a tribal member that would actually help to make sure that would check on these individuals whose health was not in the best of shape, to make sure they had their medications. And when it was in its early stages, that's the way it operated. But now my understanding is, with travel, et cetera, they end up being really more of a personal driver to make sure that individuals get to their dialysis appointments. They do the best they can, but they are, again, sorely limited in numbers. The state also has a community health worker program that they've had funding for, that where you can actually bill for services. And we have toyed with that idea as well. And that's a layperson that's trained to provide these services, but it's a layperson that lives in that community. But again, then you need somebody that is willing to be that supervisory source, to be the supervisor, to do the billing mechanism, et cetera. But yes, Carla, thank you for bringing that up, because that's an excellent point.
Crystal, you look like you have a question. You raised your hand. Go ahead.
Good morning. Yeah, thank you for bringing this topic. Thank you, Mary, for all your
information. So it's weird that this came up today because my son just entered palliative care yesterday, and he's been dealing with he had liver failure and kidney failure. So it started back in November, and they put him on dialysis, but the dialysis is doing more harm than good now, and nothing is improving. My son is 35 years old, and so they put him on palliative care and yesterday. And so a year ago, they put my mom on palliative care in January of last year. So, you know, in 18 years ago, my niece was like 23 years old, and she had cancer, and they put her in hospice. And so after her death, I took hospice training because I wanted to learn more, because there were a lot of questions. You know, traditionally, as I'm Dakota from Sisseton on the northeast side of South Dakota. So we traditionally, Native Americans, we have, you know, in our background, in our history, you know, we're always operating as one tribe, one Oyate, one family. And so, you know, the thought of, you know, you got to fill out this paper, you got to fill out this form, you got to buy a life insurance, you got to do all this. You know, a lot of times we don't do those things. Some do, yes, you know, like do work and stuff, but traditionally, you know, when somebody goes, the family, you know, that I know, all the times I've experienced come together. You know, like right now, I've got my sister lives in Michigan. She's an RN. She's going to be heading this way as soon as the roads clear in Michigan. They've got a lot of ice through the storm, but she's going to be heading here, and she'll, you know, she'll be taking care of my son. As soon as the interstate opens and they get drained, because he has a lot of fluid in his lung and in his stomach from his liver failure. So they're going to put a drain on him. And we watched a 15-minute video yesterday about how to drain that, turn on that little spout and, you know, drain him when he can't breathe that much. And so the people from the palliative care hospice, and like Mary was saying, it's such a fine line, you know, and because of the money, you know, the funding and how the hospitals get their money. But I really love the hospice program. The palliative care teams, they came in and they're just so, you know, my son right now at this point is like open. He's like, Mom, he's been suffering. Dialysis did not do well with him. So he's been suffering, and he said, Mom, I just want to lay down and let the ancestors come and get me. You know, when are they going to get here? And then now he's like, as soon as they put this drain in me and the interstate opens, he said, I want to get home before, you know, the transition starts. And the guy is 35 years old, and he's got me amazed. He's keeping me strong, you know, because he's my baby boy. And but it's like he is keeping me strong with his attitude on death and dying. And he's just like, I'm ready. And he told his brothers and sisters, he said, the only thing he said I don't want is you guys don't be fighting over materialistic things when I go. And take care of my partner, Brandon. He said, take care of him. Don't be fighting. And I was like, son, what kind of materialistic, you know, things are there? And he was like, it's nothing. He has no money. He has no land. But for him, the materialistic things are maybe a t-shirt, because those, as Dakota people, you know, we all want to have like maybe a t-shirt. We want to have, you know, when my mom was dying and I had to tell her, get the news, she always wore rings on every finger, and she took off a ring and she gave it to me, and she said, make sure, you know, Rita gets this ring. And that's how, that was it, you know, because, well, of course, a year before her passing, we went to the BIA. And that's another thing Natives can do, the tribal members, is they can go to the BIA office at their agencies, and then they can fill out those end of life wills, or, you know, they have notaries there, and they can help them do that. If they've got land, they can help them, you know, put that land, they can have a living will and put that land over to somebody else if they have it. But I just wanted to just hop on and say, you know, I was shocked when I heard, you know, you talking about this, because going through it right now is really very difficult. But, you know, like I said, my son keeps me strong, and all these resources out there that we have, I would too, like Betty said, Mary, I would like to maybe start something, or I'm a community worker. I get involved with my community in Sisseton, and I'd like to try to push the effort too of just having people prepare, because I've seen a lot of fights on the reservation where families fight. They fight over, I want his moccasins, or give me this, or give me that, and they go in and they just, sometimes I've seen they take things and they fight at the end, and there's a lot of breakups of families because of that. So it's just, this whole, I guess for natives, where we come from, a lot of this Western stuff is still very new to us, as we're still trying to get it, but it's like, if we don't want to get it because we don't want to lose who we are, so we just do the things we do. And sometimes people, the nurses, they come into homes across the reservations and they don't understand, but we're just human beings. We love our families. We want to gather around and take care of them. If that means changing a dirty diaper, then, as an adult, we just do what we have to do. And I think in the most part, we all pretty much pull together. And but I would, in the future, like to be involved in explaining, maybe sharing some stories, and just, hooking up people together to talk more about hospice and end of life care, because it's beautiful, it's normal, and a lot of people are messaging saying, oh, is it okay if I ask this, or am I being insensitive? And I'm like, no. And Mo, my son, he's like, no. He said, whatever you want to ask, go ahead and ask. But he said, I just want to be home in my own bed before it starts, before this transitioning starts. So to me, that's at 35, that's pretty remarkable. And I hope when my time comes that I have the time to plan, which is now, the strength and the courage to accept that, that movement onto the other world. But I think it's harder for the ones that are left behind than the one that gets to go, So thank you for allowing me to listen. Thank you all for your good.
Yeah. Thank you. I will add, Crystal, that I think we don't understand most of this stuff either. We like to pretend that we do. And we like, like a lot of the things that people say, oh, the people in the tribes we don't understand that stuff. They assume that somebody's assuming that the rest of us understand it. We don't, and but let's say we're too proud to admit it, because we think we're supposed to understand it, and we're somehow less than if we don't. But it's not in our DNA to know this stuff. It's not like we have to learn it. Somebody has to, how to say, ring the bell and get school in session. We're coming up actually on the end of our session here. And I just want to give Mary a chance to add any closing thoughts that she might have before we bail out at 11:30.
Well, I would also like to thank Crystal for sharing your story, because especially at the time that you are in right now, it's incredibly emotional and tugs at the heartstrings. And for you to be able to share it as eloquently as you did, I thank you for that. And everything that you talked about this, at the end of life and the fighting that happens, that's exactly what my elders talked about when we had those meetings, and that's that you can hear that colonization coming through, because that isn't your traditional ways where, material things were not important, but unfortunately colonization has had that effect. So how do we ensure, and your son is trying to make sure that happens by saying, this is what I want to happen. And having those conversations. And I would encourage everyone, I'd hope to talk a little bit more about the work in our tribal communities and really helping individuals to understand the health disparities. We talked a little bit about that and what it led into, which is my passion, palliative and end-of-life care. But I think also recognizing that in this rural state of South Dakota, where we have nearly 10% of our population is American Indian, that we need to all reach out and to understand each other better so that we can support the entire state instead of just certain pockets of the state. And by reaching out and building these bridges, you know, now having this connection with Carla is tremendous, and recognizing our different rural areas, that maybe we can get these programs up and going because of using the resources that we have and creating our own common connections and love for each other. So thank you so much.
That's wonderful. Thank you so much. And I want to thank all of the other folks who joined in and contributed. These are the kind of issues that we hope to deal with here on Brainstorming the Human Connection, because all of us can help each other. And it is through knowing that we all have these problems, we can see that, you know, the things that people are struggling with on the res, that's the stuff we struggle with. So why are we struggling separately when we can be cooperative? Why you know, the fact that we can recognize that we have this problem, even if the person is not on the res, recognize that other people have these problems too, and we can all help each other. None of us can do everything. All of us can do something. Let's just do that. Thanks, everyone, and we'll see you next week, same time, same station. Stay healthy.
Thank you.